Good day. We're so very glad that you could join us for this presentation. We have with us today James Campbell, who is an expert with over 29 years of experience. His credentials are LPC, LAC, MAC, AADC, and he has worked professionally in the human services field for over 29 years in a wide range of clinical settings. And he currently serves as the Associate Director for the Southeast Addiction Technology Transfer Center. His passion is equipping providers to support individual and family wellness effectively and build on the strengths they possess. He's a member of both NAADAC and ACA and is a nationally recognized author and speaker. So we are very pleased to have Mr. Campbell with us today. The reason this topic is so very vital is because according to a Department of Health and Human Services survey in 2023, approximately 46.3 million people aged 12 or older met the applicable DSM-5 criteria for having a substance use disorder. This accounts for 16.5% of the population in the US and shows that it is essential to continue efforts to expand access to treatment and recovery supports. Leveraging telehealth modalities may be a resource to improve the health outcomes for people experiencing or recovering from substance use disorders. So it's my pleasure to introduce James Campbell as he discusses this timely topic with us today.
Well, thank you so much. It's a pleasure to be here today and to share on this subject of mental health and substance use disorders in America, leveraging telehealth technology. As was mentioned just a moment ago, I'm a part of the Southeast Addiction Technology Transfer Center, where I serve as Associate Director. There are actually three types of technology transfer centers. Those include addiction, where I serve prevention and also mental health. They all fall under the broader umbrella that is provided by SAMHSA, and that is the source of our funding. At our heart, what we really focus our time, efforts, and energy on doing is taking things that we know from research work, things that are evidence-based practice, and seeking to turn those things into practice-based evidence, to get those off of the shelves and the three-ring binders and into the offices, group rooms, and programs where they can actually benefit those that we serve. And that's at the heart of all that we do. We're actually housed at Southeast Addiction Technology Transfer Center at the National Center of Primary Care at Morehouse School of Medicine in Atlanta, Georgia. That said, we get to serve 8 states, those that you see in the blue on the bottom right, across the Southeast, ranging from Mississippi to Kentucky, the Carolinas, Georgia, Alabama, Tennessee, and Florida. During our time together today, the objectives that we hope to meet during our time is that all participants in this session will be able to describe some of the general trends that we're seeing regarding the scope of mental health and substance use disorders in the U.S., that you'll be able to list 2 challenges and 2 benefits of utilizing telehealth, and apply potential telehealth and electronic supports for recovery from mental health and substance use disorders by applying those to some case studies that we'll take a look at toward the end of our time today. So what are some of the current trends related to mental health and substance use in the United States? First, 1 in 5 United States adults experience mental illness each year. 1 in 20 U.S. adults experience serious mental illness each year. 1 in 6 youths in the U.S. aged 6 to 17 experience a mental health disorder each year. Half, 50% of all lifetime mental illness begins by age 14 and 75% by age 24. In other words, the onset of mental illness and mental disorders usually happens earlier in life and can be picked up on and addressed earlier in life. And suicide is the second leading cause of death among people ages 10 to 14. That's a very young demographic and a very concerning statistic. Those statistics come from NAMI in 2024, so those are about as current as we have access to today. In addition to that, substance use continues to exact a significant toll on the U.S. population. With the cost of substance use disorders in the United States, including the use of illegal drugs, alcohol, and tobacco, is more than 740 billion with a B dollars a year and growing. Substance use disorders and mental disorders are among the leading causes of disability in the United States. Among people aged 12 and up, about 17% had a substance use disorder in the past year. Almost 1 in 4 adults age 18 or older had any mental illness in the past year as well. So, again, those are some significant statistics that we're seeing there, with almost 1 in 5 having a substance use disorder. Illicitly manufactured fentanyl continues to drive the majority of drug overdose. There's a strong correlation between the presence of fentanyl and drug overdose, and we hear a great deal about that in the news. But the mortality rates due to cocaine and other stimulants, things like methamphetamine, are also on the rise, both with and without the presence of fentanyl. So overdose is continuing to rise aside from fentanyl as well. In addition, alcohol continues to have a significant impact on the United States population, and one that was made even more pronounced during the COVID pandemic. Rates of substance use do vary a bit by race and ethnicity, with people of color often reporting higher rates of use than white individuals as well. I also think it's important to note that although we hear a great deal about the opioid epidemic, alcohol still has a greater fatality rate overall in terms of lifestyle related impact and long-term use than opioids does. Similar trends in racial and ethnic disparities are revealed in the 2020 drug overdose death rates. And it was found that from 2019 to 2020, drug overdose deaths increased by 44% among non-Hispanic Black individuals and 39% among non-Hispanic American Indian or Alaska Native individuals. And most people who died by drug overdose had no evidence of substance use disorder treatment before their deaths. I think that's an important thing to consider, that among those people who are actually dying from overdose, the majority of those people had never had any substance use disorder ahead of their death. So there's a significant need for earlier intervention than what we've seen as well. Despite that high prevalence of substance use and mental health disorders, many people who require behavioral health services don't get the quality care that they need, due in part because of the behavioral health workforce shortages. We know that there's a shortage in terms of counselors, clinicians, in some cases, nurses and physicians, in order to meet the needs related to behavioral health. In addition, there are deficiencies in knowledge, skills, and capacity across the behavioral health workforce to meet the unmet needs of diverse and underserved populations. So let me break that apart for just a moment. As we've seen a lot of turnover in our profession, in the behavioral health workforce, what we see is that we lose a lot of our experienced personnel, and those people who are stepping in to stand in the gap and to seek to meet the needs of those who are walking through the door oftentimes don't have the depth of experience that those who are leaving do. So there's that gap in terms of knowledge, skills, and capacity. On top of that, if they do have the skill set to just generally address addiction and mental health disorders, they may not have the cultural humility, the cultural capacity to really serve effectively diverse and underserved populations. So it's sort of a place of intersectionality, if you will. There's already a lack of qualified candidates, and qualified candidates who can effectively serve underserved populations is an even smaller number. The Health Resources and Services Administration, or HRSA projects, project substantial shortage of addiction and mental health counselors, psychologists, and psychiatrists in 2036. So in other words, forecasting out, they don't anticipate that workforce shortage getting better. Further, HRSA reports that the majority of the behavioral health workforce identifies as female and non-Hispanic white and may not be representative of the communities that they serve. Now, obviously, we want representation of all different demographics in terms of the workforce for behavioral health. What this is indicating is that on average today, the average worker in the behavioral health field is going to be a white female, whereas the population being served is not dominantly white female. And so in that regard, there isn't adequate representation in terms of the workforce that we have as well. To that said, technology can play a significant role in helping to meet some of the needs that are out there. And they really can do that in a couple of different ways that we'll explore briefly today. One of those is telehealth. And telehealth refers to the delivery of clinical services through virtual means. In other words, you have a person who is a therapist or a counselor who has the correct credentials to be able to provide clinical therapeutic services. And they're using telehealth or virtual platform as a means to do that. That is different, however, from virtual supports. Virtual supports might include a large range of non-clinical services that are often informal and non-billable. Those could be things like recovery support apps. Those could be behavioral health apps, things of that nature that can really be of benefit. And those range widely in terms of what they do and their impact. Some of those are simply sort of a quote a day or a positive thought per day. Some of those include things like mood journaling as a feature of the app that it may include. Some of those may also entail things like being location enabled and helping people find support services or mutual aid meetings, things of that nature as well. So they really do vary pretty widely in terms of what they have the bandwidth and the capacity to do to help support a person who's struggling in terms of mental health or substance use. But we know that no change is without challenges, and we certainly have some challenges related to telehealth. There are a number of those that are pretty well documented in the literature. One of those is literal bandwidth. We may joke and hear a lot about the bandwidth of us as human beings and juggling multiple responsibilities and that sort of thing. But here we're talking about actual technical bandwidth for Wi-Fi or broadband. The ability to deliver services is going to be impeded or hindered if there isn't adequate Wi-Fi in order to deliver those services in the area where those who need them may reside. And we know that that isn't equitable from community to community, sometimes even street to street. That can vary pretty widely. Provider and patient relationships can certainly also play a factor in that. And what we mean by that is at what point do the laws or the regulations within a given state identify a person as the patient of a provider? The reason that matters is that sometimes a person has to be seen in person first in order to be considered a client or a patient. And so that makes a difference in terms of permission to treat, in terms of reimbursement, and many of those other factors as well. There are also sometimes some questions about the efficacy of telehealth. Is telehealth as effective as in-person treatment? And the short answer to that is research indicates yes, that in general, it is at least as effective as in-person service provision. Now, at times you'll get some pushback from that from providers, people who are not quite sure that is accurate. And certainly, anecdotally, there are examples of people who may not connect as well that way. That can be both on the client side. Not all clients are equally comfortable with technology, and not all providers are equally comfortable with that technology as well. So when we think about the efficacy part, there is certainly a comfort level issue that we'll address a little bit further into today's content as well. But in general, they have been demonstrated to be just as effective as in-person clinical services. Confidentiality poses some different, distinct challenges in telehealth. It's possible for you to be doing a session with someone and someone else be sitting in the room and you not know that. It is possible for that to be in the midst of a group intervention. You might be doing group therapy via telehealth. And in that case, you may have somebody who's sitting in the room, and so everyone's confidentiality and protected information is being violated. That can be certainly a point of concern. And we'll talk about some ways to help address and mitigate that in our time together as well. Billing and reimbursement is a consideration. Telehealth is not equally billable in all states as well. So it's incumbent upon us as providers to know what services can be reimbursed for virtual providing, what services may not be eligible for reimbursement. Those are things that is really incumbent upon the provider to find out. Now, there are some professional organizations that may assist with that. Again, a couple of those may include the American Counseling Association. NADAC on the substance use side can help provide some guidance in that direction. But in general, it's ultimately going to fall on the provider to make sure that their services are indeed reimbursable. That's also to make sure that there aren't cases of fraud. And as I alluded to earlier, the comfort level varies very widely based on the personality of the person. Some people just prefer to talk in person. Some of that, not to be ageist in any way, but some of that does follow along a curve related to age and what generation, whether someone is a technology immigrant versus whether someone is a technology native. In general, younger people are more comfortable with virtual services than the older population. Now, obviously, that is a stereotype and not true for everyone, but that is an important point of consideration. There are, on the other hand, many benefits related to telehealth and to virtual supports as well. Many of those revolve around access to care, and that can be for many different reasons. One of those is transportation. I've been doing this work almost 3 decades, and what I can tell you is that transportation has been a significant barrier for access to treatment for the duration of that 30 years. If someone doesn't happen to be on a bus route or resides in a place where there is no bus route, they don't have a car themselves or transportation themselves, or maybe their license was suspended because of a DUI or driving under the influence. Those things can create some significant barriers to being able to get to the services that they may even be mandated to attend. So that can certainly be a point of tension and a point of struggle as well. Even if there are other services available, whether that be, again, a bus line or Uber or Lyft or something like that, that can have a significant fiscal impact if there isn't financial means to pay for that. That can be a large price impact particularly on families that maybe are not as fiscally well off. That can be a concern as well. Well, when we have telehealth, it removes that as a barrier in the same way. People are able to log in, assuming they do have the bandwidth that we mentioned earlier, regardless of whether they have transportation or not. Another major factor to consider in that arena as well is childcare. In many cases, you might have a single parent or single guardian household. And if that person is then mandated or chooses to enter into some sort of treatment, what happens in terms of childcare? Not everyone's recovery capital, not everyone's support system are the same, and so not everyone has someone who is safe and consistent and stable to watch their children while they attend any sort of treatment. Well, if in the world of telehealth, if assuming they are not an infant and that there's no crisis, a person can generally be able to be in their home while maybe the child is in another room or something to that effect. But childcare is not as significant of a barrier by virtue of the fact a person's able to receive their services virtually. Also, it's been considered that telehealth and virtual supports reduce stigma as a barrier. Sometimes people don't want to be seen coming out of a treatment facility or a program. Unfortunately, stigma is still very much alive and well. And so some people don't want anyone to know about the issue that they're struggling with. And in terms of both anonymity, confidentiality, HIPAA, federal regulation 42 CFR, they don't have to disclose that they're engaged in any sort of treatment, certainly. So this gives them a means that from the privacy of their home or the privacy of the location of their choosing, they're able to get the services that they need as well without as much risk of their diagnoses or the struggles that they may be facing becoming known. And last is comfort. I mentioned that digital divide, if you will, the technological natives, but there are other considerations in that mix as well. Again, oftentimes people have commingling disorders. Some call them co-occurring disorders. Um, if that's the case, and say someone has an alcohol use disorder, but they also have social anxiety, um, they may not be comfortable or at a place where they're able yet to walk into a room full of strangers and share how they feel. In some cases, however, they are more at ease and more comfortable meeting virtually through telehealth or through virtual platforms. So it can help alleviate or navigate some of that social anxiety for those that we serve as well, and can be a support in that direction. A few additional potential benefits related to telehealth and virtual supports is that in general, it's more cost effective for the provider. If you have a staff that is working remotely or working virtually, you may require less office space. Uh, that's a plus. You're not having to pay as much in rent, assuming that you're able to adapt where your location is accordingly. So they can be more cost effective in that regard. It also helps reduce patient or client travel and wait times. Travel we've already spoken to, but again, this is primarily focused on substance use and mental health. But think about it: wait times in, say, an emergency room. If some of those things can be screened out virtually, that provides a good opportunity to reduce wait times for everyone while giving the support to the individual that they need. Likewise, that can certainly be true for getting access or getting admission into a treatment program. There are usually limits on the number of people that can be in a particular type of service, whether that's group therapy or substance abuse counseling or something like that. There are usually caps on that, but sometimes there are limitations just based on the physical structure of a room. In other words, they might be able to have up to 12 or 16 in a group intervention, but there may only be room in the room for 8 to 10. So in that regard, it helps to lower those wait times as well by utilizing the space that we do have as effectively as we possibly can. Increased patient satisfaction is also something that we generally see for those individuals who participate in telehealth. Largely, they prefer and find it more satisfying to engage in telehealth than in person treatment. That's a significant finding as well, because people who are more content with their services are more likely to remain engaged, which helps with retention as well. Again, fewer emergency room contacts and hospitalizations matter from a practical logistical standpoint, but also in many places that is an outcome measure for programs as well. They look at whether or not the number of emergency room visits decreased from intake or assessment versus follow-up. So that can be a way of impacting and making a difference in that regard as well. Also, if the individual is able to receive more adequate care through virtual and telehealth, then that means they are less likely to progress and continue to need a higher level of care or hospitalizations in some cases. So again, that can be a better service to the client or the patient as well. And those statistics and information come from the National Institutes of Health in 2021. There are a few additional considerations that I think are important. And to be transparent, these are in part from reading and research, but they're also in part drawn from my personal experiences in providing services in this regard and working with people who are. So these are a few things that I think are good additions, just to make sure that we're thinking through the considerations that we need to if we're considering providing telehealth and how to do that most effectively. First of all, we should include information about telehealth in our informed consent. Informed consent is one of those things that we have to have in order to provide treatment effectively to clients and patients. Well, we might want to include things like the things we're required to, obviously, that we do indeed provide telehealth. This is what the cost is of that service. Those things that we're required from a fiduciary standpoint in terms of responsibility to provide. But we also want to include things around confidentiality and what that looks like, and what we request that they do. And I've seen this vary pretty widely. Some places and some organizations and programs say simply verbally acknowledge that there's no one else present in the room but you. I've also seen others who will actually ask if they will take their laptop, if they have one, or their phone if they're doing it via phone, and basically just scan visually the room, basically turn it so that the camera sees that there's no one else present. Again, putting that into the informed consent just helps allay concerns. It helps manage expectations, decrease any anxiety about that. Again, sometimes people are concerned about whether the information is truly going to be confidential. So we're doing everything that we can in that regard to help ensure that we are making people safe and secure. Also, by individual clinician, if this is an area where you have expertise and training, because it is important to have training related to telehealth services if we're going to be providing them. It's a good place to highlight that as something that you can offer, that you are equipped to be able to offer, and just to acknowledge that you have training or expertise in that arena. Confidentiality, we already alluded to. Now, I don't mean to give the impression at all that confidentiality is a new concern in the world of telehealth. It really is not. I've known of scenarios before where an individual who went into group counseling had their cell phone with them in their pocket, put it on record as a voice recording, and recorded a session of group therapy, which was a violation of everyone's confidentiality. Obviously, that is a significant concern. And so we want to do everything in our power to help mitigate the risk of breaches in confidentiality as well. Also, I've known of scenarios where, again, an individual who was in a virtual session set up their camera, their phone camera off screen to video record the session itself. Again, that would be a major breach of confidentiality, a major point of concern, and that's why some people do the sweep with the camera to help mitigate that risk as well. Again, the main thing is we want to be sure that we're doing everything in our power to demonstrate a good faith effort to ensure the confidentiality of those that we serve. That also includes things like setting up passwords so not just anyone can join your group room at any point. Because if a former client who's no longer in your care still has your passcode, still has the room number, et cetera, or the room link, they may just join in a session that they are not a part of, even if they're no longer your client. So being mindful of those things can be at least be a protection or a hedge that helps us be as careful and effective as possible with ensuring confidentiality. Another consideration for telehealth that's incredibly important to me is safety protocols. In-person services almost always have policies and procedures around things like what if the client is expressing suicidal ideation or is considering a suicide attempt? What happens if the person seems to be under the influence or even possibly overdoses? In a group room or in a client or a counselor office, there are protocols to address that. We need to make sure that we have some protocols in place for virtual provision of services as well. It could be that a person, in theory, in the middle of an individual session with a counselor, could do something to harm themselves in real time. Well, that being the case, making sure that we are have the procedures in place to be able to try to connect with emergency services, that we know a viable address, hopefully where that individual is, so that we need a safety check or something along those lines. We have the ability to reach out and to request that can be incredibly important, or to contact first responders in the case of an overdose so that Narcan or naloxone might be able to be administered more quickly to reverse an overdose. Giving some thought to those safety protocols on the front end is incredibly important to helping ensure that our clients and patients and all those that we serve are as healthy and as safe as we can possibly keep them. Again, none of these things are foolproof, whether in person or virtual, but we want to make sure that we're doing everything in our power to ensure the safety and the confidentiality and quality care of those that we serve as well. Now here, I'd like to move from the more theoretical and research-based to things that are a bit more practical. There are actually 3 case studies that we will take a look at. What I'm going to encourage you to do is on each of these, I'm going to provide the basic information on the case. Then I'm going to ask you to pause the video for just a couple of minutes to think through how you might respond and how you might or might not use telehealth or virtual supports in the case of this individual. They are in different settings, so as we go through, you will see that that may look a little bit different as well. But depending on where you're serving, hopefully that will touch on something that's similar enough that you're able to consider ways you might be able to apply telehealth and those virtual supports as well. For our first case study, that we'll cover in just a moment, it will take a look at one gentleman. But I do want to just acknowledge that the first two of these case studies were taken from e-mental health case scenarios and frequently asked questions that came from the Mental Health Commission of Canada. They actually have some great resources there, and so I always like to give credit where my sources come from as well. If you ever have a desire to do a deeper dive, they have more case studies than what are included here as well and can provide some good food for thought. So our first scenario is Bill. Bill is a 59-year-old retired mechanic, and he visits his family physician for an annual checkup. He says he's noticed some changes in his appetite and sleep patterns since retiring almost a year ago. He also mentions that he feels little purpose in his day-to-day life and sometimes lacks motivation to leave his house or make plans with others. Now, again, obviously, this is not in depth. This is not a deep dive into all the things we might know from an assessment. But just considering the information that we have in front of us, press pause for just a moment and consider if there are ways that you might utilize telehealth or that you might utilize virtual supports with Bill. All right. Coming back on a conversation for Bill, there are a few things that we'll consider in terms of what was done by his physician, because he was visiting his primary care doctor, and what his physician did. In this case, since Bill's in good overall physical health, the physician talked with him about his general mental well-being and mood. Together, they discuss options for helping him manage his low mood and increase his activity levels, and hopefully find some relief for some of his mild depressive symptoms. The physician recommends that Bill create a log of his mood and sleep patterns daily and schedule time for hobbies or other activities he enjoys. He also says there are a number of mobile mood tracking apps he could download to his phone. Bill initially shrugs at the idea of a mood diary, but he does say that if he were to keep one, he'd prefer to use an app over having to write things down. The physician offers to review the diary logs at the next appointment to see if things are improving or if other supports are needed. Bill tells him he'll give it a try. So again, it may not have been what you initially thought of or the first thing that came to mind as you considered it, but here's a situation where initially, before jumping to medications, before jumping to formalized treatment, the physician decided to use some more behavioral approaches of encouraging him to get out and get engaged in some hobbies, things of that nature, to see if that makes a difference, and also using technology to track his mood over time as well, to begin to see if there are any patterns related there too. Now, mood logs are fairly standard issue within the clinical world. Many people use them, many clinicians use them. This is just a means of doing that digitally. Now, in addition to the fact that some people would just prefer to do it digitally, some people also feel that it actually gives them an extra level of safety and anonymity. If you write something down on paper and someone finds it, well, they could sit and read everything that you wrote or look at your mood over the past however long you've been recording it. But generally speaking, technology is at least going to be password protected. So for some people are more comfortable being able to put that into an app versus doing a handwritten version of that. So are there any other considerations there with related to Bill and related to his case? Well, here's a few things to consider. Are e-mental health apps an appropriate option for somebody like Bill? Now, Bill expresses a willingness to do that, but as we all know, not everyone who agrees to something in a doctor's office or clinician office follows through once they get home. So it may be useful to just take a moment and ask, which app are you interested in using? Can we go ahead and download it to make sure that you're comfortable using it and know where that feature is? Those are things we can do to help navigate that and mitigate the likelihood that it just doesn't get implemented. What are some reasons Bill might initially hesitate to use an app to monitor his mood? Well, again, it may be that he's just not really on board with the idea, period. Again, he doesn't seem exactly eager to track his mood in general. But if he's going to do it, he expressed that he's more willing to do that using an app as well. So you do have to tease out what might be someone who has a little bit of ambivalence about doing a task at all versus what part of that ambivalence might be technology based. What assumptions do clinicians sometimes make about patients when recommending mental health apps? They might assume that everyone has access to a smartphone, that everyone has access to a tablet, that everyone has access to the bandwidth to be able to do that. Again, depending on the individual, and particularly if they have limited financial means, that may be something that is not something they readily have available. You also may make assumptions based again on the age of the person that you're seeing. You may assume that young people are more open to technology when in general that's probably true. But the reality is that there's some young people who do not have a desire to do telehealth or virtual sessions as well, or don't have a desire to use those virtual supports. They may have concerns about whether that's going to be tracked. They're collecting all this data about moods. Are they doing anything with that? So again, those are concerns that you can encourage them, or again, depending on time and location, you may even look at what the disclosure statement for the app says or what the privacy statement for the app says. Again, those are some considerations, just things to ponder related to the clients that we serve as well. And what did the clinician do to increase the likelihood that Bill would use the app after following the appointment? One thing that the physician did is said they would take a look at it when he comes back next. So there's a degree of accountability, if you will. We will use this. It's not just something to do for the joy of doing it. Let's take a look at it together. We consider this important enough to invest some time and effort into in our time together when we meet next as well. Again, there are other things that we alluded to before, whether or not you make sure and that the person knows how to download an app, that they know how to access it, that they're able to use it. Those sorts of considerations can make a significant impact in terms of follow through and efficacy of some of those some of those supports in terms of recovery, be that from mental health disorders or substance use disorders as well. So that's a brief summary of Bill. And hopefully that began to put a little bit of skin on the bones, if you will, about what it looks like in real life, real time, how that might apply with a client or with a patient. Hopefully that gives a little bit of food for thought. But certainly that's not the only scenario or type of scenario that we might encounter. So just as before, we'll take a few moments to look at our next scenario. And just as before, I'm going to ask that you pause at the end of the initial description, give some thought to what you might do, how you might intervene, or what you might recommend. And then we'll see how that plays out with the person that the individual was seeing. Scenario 2 is Kaylee. Kaylee is a 24-year-old student who recently enrolled in a master's program. During her second semester, she went to the Student Wellness and Counseling Center to get help for her feelings of anxiety. In the waiting room, Kaylee completed an online intake form that included a standardized behavioral health measure to assess her mood, daily functioning levels, severity of symptoms, risk of suicide, and readiness for psychotherapy. During her initial assessment, the staff therapist asked Kaylee about her current stressors and concerns. Kaylee said she was feeling pressure to do well in school and was very lonely since moving away from home. When asked about her coping strategies, support network, and desire to improve, she said her family was supporting her and she was motivated to do what she needed to do to feel better. Overall, the therapist felt that Kaylee demonstrated a high level of self-awareness and mental health literacy. So again, this scenario is a little bit different. Rather than being a physician in an office, this is a counselor in a school setting. And again, you have Kaylee coming in presenting with anxiety. Just as before, pause here, take a moment to consider what you might recommend or how you might intervene. And then we will see how the clinician in this case responded. What did they recommend? What course did they take? Welcome back. And following up on Kaylee and considering what things were actually recommended by the person in this scenario, let's take a moment to see if those align with what you might recommend or what you felt most appropriate. In light of their discussion, the therapist ranked Kaylee's anxiety symptoms mild to moderate and her risk of self harm low. Accordingly, she presented a low intensity behavioral treatment plan and suggested Kaylee take advantage of certain interactive online self help resources, such as mobile apps and web based programs that use evidence based cognitive behavior therapy techniques. As well, she provided Kaylee with the university's social events calendar and discussed opportunities for her to meet new people and make friends. After recording the treatment plan they developed together, the therapist gave Kaylee a copy. It indicated her current step, her chosen online treatment options, and the therapist's contact information. As she told Kaylee, the plan was meant to be tentative and flexible. So she should request a follow up session if she notices a change in her mental health or if the online self directed resources did not help abate her anxiety or help mitigate her anxiety. I wonder how that lined up with what you might have recommended. Again, this is a person who seems fairly self aware. They have some understanding about their own anxiety. They're self directed. They came in for assessment and to be seen on their own volition. And they, in some sense, have a little bit of attention. They have some anxiety and they have some sense of loneliness. And so, providing the calendar of activities could be really beneficial if she can overcome the anxiety to engage in them. So that may be a little bit of a challenge as well. Or it may be if there's somebody who is a peer that she has met, even if they're not very close yet on campus, being willing to go together sometimes can help people over that hurdle as well. One of the key factors here is that they did consider whether there was risk of suicide, whether there was any ideation, whether there was any risk of lethality. Again, we always want to do due diligence. We never want to undertreat someone. We just don't want to overtreat them as well, if at all possible. So we're trying to find that balance, if we can, between providing adequate supports versus really engaging in more formalized treatment where needed. In this case, this example doesn't really break down or explain what the web-based program that uses evidence-based cognitive behavioral techniques is. There are a couple out there that are almost like a chat feature where you'll ask a question and it'll respond. Some people find those beneficial. Some people really do not care for those very much. Sometimes it's really more of almost an educational process. So it might do like thought distortions and walk through some of those. And it really is more educational in nature. Or it could be true telehealth, true therapists providing services through a virtual platform. It doesn't really delineate here, but it is important to consider what might be the best fit for Kaylee in this situation. One thing I also really love in this example is that Kaylee and the therapist are talking about this and developing this together. Remember, treatment is always something we should do with a client and not to a client. And so in that regard, that can be a significant difference in terms of someone's follow through, whether or not they actually take the recommendations and apply them, and whether or not they find benefit in them long term. Now, just as before, there are a few things that we might want to consider in addition to what I've already mentioned. One, what aspects of personal history, readiness to change, and therapeutic alliance would you explore with a client like Kaylee before proposing an e-mental health solution? For instance, you wouldn't want her to come in and feel like she's telling you her life story, she's pouring her heart out, and you go, let me refer you to an app. That probably is not going to generally be well received. That's why it's so important that we partner with those we serve in terms of developing their plan of care as a plan, as opposed to us delegating it or doing a monologue in which we prescribe these are the things you need to do. What e-mental health resources have you prescribed to individuals like Kaylee? Again, prescribed in quotes there. But have you ever referred them to any type of virtual supports? Did you know that there are virtual mutual aid groups like AA and NA and Celebrate Recovery? Again, for someone with social anxiety, someone with general anxiety, someone who doesn't have transportation, being able to engage in that mutual support, a mutual aid group can be really, really beneficial and really helpful to them. How can an e-mental health based treatment plan be left open so it can be changed over time? Again, depending on if you're using an electronic health record versus a manual written record, that can make a significant difference. Again, in almost every scenario I can think of with both Joint Commission and with CARF, when it comes to therapeutic clinical services like counselors and therapists, the idea is that the treatment plan or plan of care is always a living document, that it's always open to change because assessment happens at every clinical contact. So that's a way of keeping that treatment plan alive, keeping it keeping it open so that it can be adjusted and changed over time. How can healthcare providers explore an individual's strengths to help them build the confidence and capacity to manage their own mental health using e-mental health services? How do we begin to do that? How do we explore strengths? The truth of the matter is that our profession is very deficit oriented. Whether if you're in the mental health or behavioral health side and the entire DSM, there is nothing curative in it. It is a list of symptoms, and we look at clusters of symptoms to make a diagnosis, but there's no recommendation for treatment in the entire DSM and the Diagnostic and Statistic Manual. So for us, exploring strengths has to be an active intention because the need for ICD codes, the need for diagnoses, the need to write a problem statement on a treatment plan all tend to orient us toward the negative. When the fact of the matter is, nobody gets out of a hole by staring at the bottom. How do we leverage the strengths, the supports in that person's life to help them navigate and mitigate the places that they do struggle? That shift can make a significant difference in those that we serve as well. And that also will help them to build the confidence and capacity to manage their own mental health. One of the things that we don't want to do is foster dependence, where we're providing services, but as we provide the services, we're actually making the individual more and more dependent on us because we become the main primary source of support that they have in terms of their recovery. While it is completely appropriate for us to be a means of support if we're providing clinical services, we never want to be the only one. In general, when you talk about alcohol and drug use, if it's been prolonged and significant, it usually takes the neurotransmitter levels about a year to get back to baseline. Most clinical programs do not last a year. For that reason, it is important from the very beginning that we be trying to connect the individuals that we serve to the broader support systems in their community. Again, whether that's mutual aid groups, whether that is grief support groups, whatever that happens to look like, whether that's NAMI, which is the National Alliance for Mental Illness, which is an advocacy group for mental health. There's Faces and Voices of Recovery, which is an advocacy group related to substance use disorder and recovery therefrom. Those can be major factors in helping individuals to get better as well. Which other providers or support persons, whether that's peers, caregivers, graduate programs, Indigenous elders, might help young people use e-mental health services as well? Again, depending on the population that you're serving, in general, people are more likely to hear advice that's coming from someone they consider to be similar to them. That sort of goes back to representation and making sure that we have adequate workforce that is representative. But where we don't have that, we need to make sure that we're being intentional and connecting with people of influence within various communities so that they can indeed engage in and recommend services or following up on services, or sometimes educate us about why a recommendation may not be as appropriate. So that's a two-way street as well. So again, that's some points to consider, food for thought around Kaylee. The last example we will use today is a little bit different. And this one, I'm going to start out the same as before. It provides a little bit of brief information on an individual. Just like before, we'll pause, but you'll see that there's a little bit of a difference that comes after that fact. This scenario is Douglas. Douglas is a 32-year-old Black male who has been struggling with alcohol use and depression. Upon assessment in your outpatient program, Douglas meets criteria for moderate alcohol use disorder and depression. He admits to some suicidal ideation in the past, but denies any at the time of the assessment. Douglas recently went through a divorce. His ex wife and 2 children remained in the home they had shared, and Douglas moved into an apartment across town. Douglas works out of his apartment in the field of cybersecurity. From the assessment, outpatient treatment is merited. Douglas reports that due to his hours, attending sessions in person would be challenging. He asks if there's a virtual option for participating in treatment. Just as before, we'll pause here and give you a second to think about what might be the recommendations that you would consider for Douglas. Now, here we will see that things are a little bit different. When we consider what should happen, there isn't a list here of what the outpatient provider did. And the reason that shift exists is because it's much more true to life. Unfortunately, we don't always have the benefit of knowing what someone else would do in a given situation or what would be recommended in that situation. Certainly, there are factors that we would want to consider. The fact that he has a history of suicidal ideation, he's had multiple recent life transitions that would probably result in a lessening of his social supports to some regard. He is probably living alone, and so that's a consideration as well. So whether or not we engage in virtual or telehealth services might depend a little bit on what his level of suicidal ideation is and what lethality looks like for him. The key here is that, again, we want it to be a collaborative discussion. We could certainly stick to our guns and dictate that you must go to in-person services, but the reality is, unless he is mandated to do so, he may just elect to not go to any services. In that regard, some support is definitely going to be better than none. So we want to provide the best supportive care that we possibly can in a collaborative way with Douglas. Other considerations that may be further down the road is whether a referral is needed for psychiatric support, whether the individual might benefit from, say, a selective serotonin reuptake inhibitor or another medication to address some of the depressive symptoms, or whether those might abate once he is away from some of the losses that he's going through and transitions that he's enduring right now. Certainly, some clinical support does seem to be warranted. What those look like is going to not just be dependent upon you. If you hear nothing else I say during my time with you today, I hope that you will hear this. If you ever have the question cross your mind, should I staff this with someone? The answer is yes. Generally speaking, you never want to make a decision in isolation about someone's treatment. We want to collaborate with the client or the patient. We also want to staff that with other people who have expertise. Now, if you're part of a program, that's easier because there's usually interdisciplinary treatment teams or staffings. There's ways for that to occur. If, however, you should ever find yourself in private practice, that can be more challenging. Oftentimes, you will have to seek out that sort of peer support or ideally clinical supervision to help guide you in the decisions that you make. In general, what I can tell you is that people do not tend to lose their licenses and certifications based on decisions that are made in an interdisciplinary treatment team. They tend to get themselves into trouble when they make decisions apart from that kind of support, when they make decisions in isolation. For that reason, even if you are in private practice, you are functioning independently, it is very, very important that you seek out good support, good input, good advice, good supervision around the type of care that you are providing. This is particularly true because in the era of COVID-19 being not as prevalent, what we're still seeing is that a lot of very young clinicians and therapists stepped into private practice much earlier than they may have historically done. And so what that means is there are a lot of people with less experience providing clinical services through a means that does not have as much built-in support for clinical supervision, peer supervision, et cetera. So make sure that you're being safe, that you're being wise, that you're seeking out good clinical support in all that you do as well. Because unfortunately, the answers aren't always prescribed. It's not always as easy as A plus B equals C. And so we want to consider all the options to make sure that we're choosing the one that's going to be the best fit for the client and in line with good evidence-based clinical practice. So what factors should we consider for Douglas? We might also consider things, again, think back to early in our session when we talked about representation. We talked about making sure that we had a workforce that was representative of those that we serve. As a Black male, is there a Black male therapist, if that is indeed what Douglas would prefer, who is able to meet those needs? Would he be more comfortable in that case? Is a consideration as well. We want to consider the safety of Douglas. He has a history of suicidal ideation. A safety plan may be something that we would definitely want to include. Should you find yourself feeling unsafe, please do the following things. That may include calling 988 or texting 988, but do some things proactively so that should he find himself in a place that is not as healthy, he has some support as well. You may want to consider the fact that he is fairly socially isolated. And even if he doesn't come in for in-person treatment, you might recommend where are some places where you found some social support in the past. Is that something you would be open to re-engaging in? Consider alcohol use and depression. It said that he had alcohol use disorder and depression, and those two things exacerbate one another. That's, again, a point that you would want to consider. You would want to ask some questions about how much alcohol is being consumed, to be mindful of the possibility of things like blood alcohol poisoning as well. So those are some considerations in addition. And again, whether or not a referral to psychiatric care, or again, if you have that in-house, being able to connect with someone to provide the psychiatric care is paramount, because that individual may well benefit from that service. And just because we may not individually, personally provide it, does not mean that the client won't benefit from it. It may be a place for referral, coordination, and linkage of care. If you should have any questions or observations, since this is an asynchronous recording, we won't be available live and in real time to provide that feedback. If, however, myself or anyone at the Southeast Addiction Technology Transfer Center can be a support, my contact information is here. I'm always more than happy to provide support in any way that I can. By all means, feel free to reach out through the means that are listed there on your screen. Without further ado, on behalf of the National Center for Primary Care and the Southeast Addiction Technology Transfer Center at Morehouse School of Medicine, thank you so much for your time, for your attention. Take good care of yourself, take good care of your loved ones, and take good care of all those who come into your care. Thank you.